Doctor, I have been coughing and there's pain in my chest.
Hello everyone, this is Dr. Stuti in Medicine Under 5 Minute series, and today we're gonna learn about pneumonia. So what is pneumonia? Pneumonia can be defined as acute respiratory illness with recently developed pulmonary shadowing, okay? So it is acute respiratory illness with recently developed radiological pulmonary shadowing. So basically there is infection causing inflammation of the lung parenchyma. So the alveoli, the air sacs, and all the ducts are involved. For example, if I show you this picture, this is the normal lung, and initially when there is infection or inflammation, first step is vasodilation and increased permeability causing congestion of the lung. So the affected area is very congested with increased blood flow. Then with more of RBCs, you find red hepatization. There is increased RBCs and congestion. Then after a few days, you may appreciate gray hepatization. That is increased WBCs, macrophages go there and phagocytize the organism and basically increase or cause fibrosis. And the last step is resolution, when there is fibrosis and healing, which occurs from day 8 to week 4. So there are 4 stages: congestion, red hepatization, gray hepatization, and resolution. What are the types of pneumonia? Based on anatomical pattern, there can be bronchopulmonary pneumonia, which is in patchy form, it can involve any area, and there can be lobar pneumonia. In lobar pneumonia, a particular lobe of the lung is involved. What are the other types? It can be hospital-acquired pneumonia, community-acquired pneumonia, pneumonia in immunocompromised, or ventilator-associated pneumonia. So the most common one is community-acquired pneumonia. It happens either in old age or in young age, extreme of ages, caused by Streptococcus pneumoniae. Then there can be hospital-acquired pneumonia, which is basically the infection that you acquire 48 hours after admission into the hospital, which is not present or incubating at the time of admission, which is mostly due to cross-contamination. Then there can be ventilator-associated pneumonia, mostly seen in ICU patients or bedridden patients who are fed when they are lying down. And in alcoholics, you may find aspirational pneumonia. And then there is another type, pneumonia in immunocompromised. So what are the risk factors? Risk factors basically includes cigarette smoking, immunocompromised due to HIV infection, or old age, or due to steroids, drugs. Then there can be previous history of upper respiratory tract infection or influenza infection. These are all the risk factors. What are the organisms causing it? There can be bacterial causes and viral causes. Viral like coronavirus, influenza virus. And bacterial cause includes some typical organism like Streptococcus pneumoniae, the most common one. Then Klebsiella pneumoniae, which causes cavitation in lungs and is seen in alcoholics. Then typical organism also includes Haemophilus influenzae, which basically affects the old people. And then there can be atypical organisms like Legionella. Legionella basically is causes local outbreak and is seen in hotel rooms, patients who stay in hotel rooms where there is an AC supply. And Mycoplasma, which happens, as the name suggests, in young people. Mycoplasma. Then there can be like Coxiella burnetii. Okay, these are all the atypical organisms. So what are the clinical features that a patient presents to you with? So number 1 is cough. Then the patient may say there is chest pain, especially during inspiration. When patient is trying to breathe, there is chest pain, or the pain can be seen even in the abdominal area if it involves the lower lobes of the lungs. Then high grade fever, okay, with chills and rigor. Fever, cough, and chest pain. Then there may be additional malaise, headache, myalgia, etc. And in case of atypical bacterial pneumonia, that is atypical organisms, you may find features like dry cough. Then extrapulmonary features like in mycoplasma, you may find ear pain, okay, or even rash. Then in case of elderly patients, the comorbid illnesses get worsened, and patient usually presents with confusion and falls. So what are the signs, or what do you find when the patient comes? So on general examination, you'll find that the patient has fever, tachycardia, tachypnea, and they can even be present with cyanosis in severe cases. And on local examination, what do you find? So consolidation happens in pneumonia. Consolidation is basically solidification of a part of the lung, right? So solidification, you can understand it better as, for example, in your lung, there is some stone or solidification. So when there is a stone in your lung, the movement of the chest is reduced, number 1. And there is stone, so respiration is reduced. And so as a result, to compensate the reduced chest movement, there is increased respiratory rate and the use of accessory muscles is increased. So you will find a reduced chest movement, tachypnea, that is increased respiratory rate and use of accessory muscles. Okay, on palpation, you may find the trachea is central or may be deviated in case of collapse, and the chest expansion is reduced. Then point to remember here is in case of solidification, vocal fremitus increases. And on percussion, imagine there's a stone, so you'll find dull note. And on auscultation, classic finding is bronchial breathing over the consolidation, and you may find added sounds like crepitations. Crepitations are usually seen in the early stages when there is congestion and during the resolution stages when everything is getting better. Okay, but in case of established consolidation, you will find bronchial breathing and increased vocal resonance. So point to remember during auscultation is bronchial breathing over consolidation, and you may find crepitations, and also there is increased of vocal resonance. What are the investigations that you would like to do? Basic investigation like CBC with CRP, ESR is done. In CBC, you'll find neutrophilia if it is bacterial. Okay, then you may find increased CRP, ESR. Then chest X-ray is done, where you will find inhomogeneous opacity occupying a single area of the lobe or in patches. So this is the classic finding, inhomogeneous opacity. And in case of organism infection by organisms like Staphylococcus aureus or Klebsiella, you may even find cavitation, which is appreciated here. Then other tests to see the severity, you can go for urea, blood urea, then serum electrolytes, especially sodium level is very important to assess severity, and you can also go for liver function test, etc., to see how severe the infection has spread. Okay, and in case of microbiological examination, you go for sputum, gram stain culture, blood culture, and in case of atypical organisms like Legionella, you also have to look for urinary antigens. Okay, so basically these features like rusty sputum guides you towards Streptococcus pneumoniae, then currant jelly is associated with Klebsiella, etc. How do you treat pneumonia? So there are some general measures, like for example, you increase the oxygen, you give oxygen supply to the patient, then hydration is maintained, especially in case of old patient. And then for pleuritic chest pain, you give analgesia like NSAIDs or paracetamol. Okay, then the main or specific treatment is the antibiotic therapy. For community-acquired pneumonia, there is one CURB 65 method of assessing the severity, in which if there is confusion present or if confusion is present, the patient gets score of 1. If respiratory rate is more than 30 per minute, score 1. Blood pressure lower than 90/60, score 1. If age is more than 65, score 1. All these can be assessed clinically, and investigation wise you can go for urea. If it is more than 7 millimole per liter, you also get a score of 1. So out of 5, depending on how much score the patient gets, we can classify them into either low risk, moderate risk, and high risk. Low risk patients can be treated in outpatient with antibiotic, oral antibiotic. Inpatient is for patients who score 2. Less than 2 are outpatient. 0 to 1 are outpatient. 2 is given for patients with moderate risk, and they are to be treated inside the hospital. And for severe patients, you may even need ICU support. These are basically 3 to 5 scorers. Okay, and in severe patients, you give injectable antibiotics, which are like ceftriaxone plus azithromycin in combinations. For atypical, you can go for macrolide and hospital-acquired pneumonia. Especially the most common one is Pseudomonas. So you go for anti-pseudomonal beta-lactam antibiotics. For monitoring, you will eventually find clinical improvement in patient within 48 to 72 hours of pneumonia, but you have to repeat the X-ray for after 6 weeks in case of smokers or age 50 or persistent symptoms. Radiologically, it takes 2 weeks for the symptoms to resolve. What are the complications? The most important part is that pneumonia may lead to pulmonary complications like parapneumonic effusion. Later may turn into empyema, lung abscess, respiratory distress syndrome, lung failure, etc. Then there can cause heart problems like pericarditis. Most important one is atrial fibrillation. Then it can also spread to kidney, causing AKI, and in brain it may cause meningitis. Then as a whole inside the body it may cause sepsis and septic shock. So pneumonia should be treated well. There is some general management as well as specific management, which is the antibiotics. And later on you can also give physiotherapy and early mobilization for patients who develop pleuritic chest pain. So thank you for watching the whole lecture. I hope you enjoyed it. Bye bye.